couple weeks, he's going to be our speaker. He's talking about dry needling, and he is a physical therapist. We're from our awesome group, and the Sports Medicine Institute, and he's at Upward. And I've heard Doug speak probably 15 times, and over the years, he's been helping me since 2005 to become a good trainer, and he's been helping me a lot. It's honestly a lot. I've come a long way with Doug help, and I do appreciate you coming to be our speaker, and he talks every year for us. Probably twice a year every year.
Try to.
Wow, that's pretty good.
Cool.
So make sure you sign in, and welcome Doug.
All right, so thank you for coming, spending your afternoon with me, eating some food. Today we're going to talk a little bit about dry needling. So objectives today is kind of define what dry needling is, compare that to acupuncture, define what a trigger point is, and then the theories behind how trigger points develop, the goal of dry needling, how we actually dry needle, and then integrating the selective functional movement assessment into our dry needling process, and then what do we do after we've done our dry needling for post-treatment. So a little video for you guys to have a little fun as we start.
Can we turn the lights down?
Yeah.
Terry Bradshaw, and I'm no stranger to the competitive arena and what can be accomplished by having an edge. Join me as I examine new programs, methods, and technology designed to give the player the edge. Whether you're an athlete, a weekend warrior, or simply an average Joe nagged by orthopedic and musculoskeletal pain, the discomfort felt from such conditions can put you on the sidelines in the big game as well as in everyday life. Just ask LSU alumnus and Tampa Bay Buccaneers linebacker Jacob Cutrera.
I was having really scary neck pain, like a sharp pain in my neck when I tilt my head back, and playing linebacker, you got to use your head, your neck's going to be involved, so I need to get this problem solved.
Elbow up. Fortunately for Cutrera, physical therapist Ricky Lane is trained in a growing physical therapy technique known as dry needling or trigger point dry needling.
Dry needling has been a tremendous adjunct to my professional practice and what I do on a daily basis. I'm on contract with LSU and I treat a tremendous amount of athletes. It's been an unbelievable tool for me in my tool chest to be able to treat athletes at a higher level and with more efficiency.
Dry needling has been performed internationally by physical therapists for over 40 years. It has increased in the U.S. since 2005 and is used today by the military, professional sports teams, and in physical therapy clinics. Organizations like Brighton, Colorado-based Kineticor are actively involved in educating and training physical therapists on the technique.
We're going to do a course on functional dry needling today.
Physical therapist and functional dry needling expert Adel Zylstra is the organization's founder and developer of functional dry needling, a movement-based variation of trigger point dry needling.
A trigger point is a spot in the muscle that can cause pain. We have active trigger points which really reproduce pain that the patient is familiar with. And that trigger point is a dysfunction of the connection between the nerve and the muscle. That in itself can cause muscle tension, which causes muscle restriction, which then limits movement function. Trigger point dry needling is utilized to deactivate the trigger point, to reset that muscle, to treat numerous painful conditions such as plantar fasciitis, low back pain, headaches. Dry needling is performed by one palpation of the dysfunctional tissue that is associated with possibly a movement, as well as the tissue that's causing pain. We then insert the needle into that tissue, trying to elicit a twitch response. That twitch response then resets how that muscle functions, improving the joint mobility, reducing pain, and really allowing us to progress that patient into more of a corrective exercise that is very specific to that movement impairment that they came in to see us for.
During the treatment, patients often feel a cramping sensation from the twitch response in the muscle being treated, often followed by immediate improvement of their symptoms.
I feel great. I wake up in the morning feeling good. I used to wake up, my neck killing me. I had to get in the hot shower just to loosen everything up. Both calves feel great. I feel even faster than before because it's so loose, and then I balled up in knots like they were before.
Any pain with that?
The technique saved Leslie Pulaski from lumbar surgery.
I had an accident a couple of years ago, well actually it's been about 8 years ago, where I got a bulge disc in my back. I was looking at lumbar surgery, I was young, scared. Ado and I were working together at the time, and he offered for me to see him regularly once a week and receive dry needling before I went forward with the surgery, and I'm so thankful I did. It absolutely saved me from the surgery, and 8 years later, still haven't had surgery, and I'm out of pain.
Connecticut offers introductory and advanced functional dry needling courses. To date, Connecticut has certified nearly 1,000 North American providers in dry needling techniques.
I see the future of dry needling as very exciting and bright for us. It gives us as physical therapists a great tool to address musculoskeletal injuries, to hopefully prevent more injuries. It's paramount that we incorporate this into training as physical therapists.
All right. So really, dry needling has really come into flavor in the past like 5 to 10 years. More and more people are coming in and asking for it. More athletes are looking for it, and it really is helping them continue to perform at their level without having to go through a lot of other soft tissue stuff. The dry needling seems to work a little bit better, a little bit faster than just doing some soft tissue stuff. But basically, dry needling is a skilled intervention using a fine filament needle to penetrate through the skin, stimulating the trigger points, the muscles, and the connective tissue, and thereby reducing the irritation, the pain in that spot, and therefore improving their pain and improving their overall function. So dry needling comparing to acupuncture. So is there a difference, and what is the difference? So acupuncture started about 8,000 years ago. There we go. The first documentation in a Chinese medicine book was around 305 BC in the Yellow Emperor's Classic Internal Medicine. So I wish all my patients were like that, where I just kind of shoot them a little bit and then they feel better. Acupuncture is based much more on keeping your energy flow, your chi in your body, allowing the energy throughout your body to flow normally. Once that energy is blocked in some way, some sort of irritation or dysfunction, the thought with the acupuncture is to treat the actual acupuncture points along these meridian lines, and that'll increase the flow and return your body back to a homeostasis. So therefore you feel better and reduce your disease, your pathology, your dysfunction. Unfortunately, modern medicine has shown that meridian lines don't really exist. Along these meridian lines are your nerves, your muscles, and these trigger points. So perhaps by treating these points, they had success, but they were really treating trigger points and not so much treating their acupuncture points and treating this energy flow that they thought they were treating. So dry needling started around 1910, where Sir William Gowers was the first one to kind of palpate this trigger point, this hard, tender spot in the muscle, all the way up to 1979, where we actually put a dry needle into a patient to actually treat somebody. So in 1910, again, Gowers was the first one to kind of palpate these trigger points, these nodules. In 1938, Kellgren was the first one to inject prolicaine directly into the trigger point to try to deactivate them, to get the muscle to relax and feel better. 1940, we had Travell and Simmons, who actually went through and mapped all the trigger points throughout our body, as well as started, Travell actually treated JFK. He had gone through 2 or 3 back surgeries, and by doing some injections and dry needling, which they use a hypodermic needle, not the needle that we use today, and actually helped JFK, and he was able to go on and be a great president. So it's had a little bit of history behind it as well. There's some current theories on how these trigger points develop. One of them is Dr. Gunn, who developed the Radiculopathic model, which we'll go over here in a little bit. But he developed, instead of it calling dry needling, he called it intermuscular stimulation. He felt it was more coming from the nerve than it was coming from the end plate or the musculoskeletal junction or the muscle junction. So he developed his own technique on how to diagnose it and actually how to treat it. And again, 1979, Carl Lewitt became the first physician to actually employ dry needling, where he used an actual dry needle, not a hypodermic needle, to help reduce pain. In 1984, Maryland became the first U.S. state to allow physical therapists to actually perform dry needling as part of their interventions. So what is a trigger point? Basically, it's a hyperirrital spot inside the muscle. You can palpate that nodule, and that nodule will be tender, can be tender in that spot as well, refer pain to another area. So these referrals, you have active trigger points, latent trigger points, and satellite trigger points. Active trigger points are actually ones that you can actually feel, so without even palpating, you'll know that there's some sort of pain, some sort of dysfunction in that area. Whereas a latent trigger point will be there, but unless you palpate it, actually put some compression into it, you won't know that you have that trigger point there. And then satellite trigger points develop in referral pattern areas. So if in your glute you have a referral pattern, say down the lateral aspect of your thigh or up into your back, you can actually have satellite trigger points in your hamstring or up into your back, but they're coming more from that active trigger point. If you treat the satellite trigger point, the patient will feel better, but you're not truly getting at the source of the problem. So you really want to make sure you're getting that active trigger point. And that's where sometimes we can get in trouble, because the active trigger point might not actually be that painful, and the other trigger points be more painful, and now you end up treating the wrong area. So you kind of have to palpate around to really figure out what area you need to treat. Cause of the trigger point, probably the biggest one we see is repetitive movement, low load, so over time just continuously doing the same thing, whether it's throwing a ball, hitting a tennis ball, swinging a golf club, whatever it is. Compressive forces trauma can definitely cause the development of our trigger points. Uncustom eccentric loading, emotional stress, which we know, having integrated EPIC here recently, a lot of our PTs are going through some emotional stress. Their posture is probably poor, and so we might have to do a little needling there. And then just being dehydrated as well. So here's some of the maps that Travell and Simmons developed over the years. You can kind of see where the trigger point is, and the pain can be referred 3, 4, 5 inches away. So you might be having pain in a certain area, but unless you go around and try to figure out where those trigger point spots are and hit those with that needle in those spots, you might be treating, again, those satellite trigger points. So theoretically, how do these trigger points develop? There's 3 concepts: the energy crisis theory, the motor end plate hypothesis, and the radiculopathic model. So basically, the energy crisis theory is that you have some sort of trauma, some sort of load onto the tissue. Because of that, you get an increase in calcium release inside the tissue. That calcium release causes shortening in your sarcomeres. Because of the shortening of your sarcomeres, the tissue stays tight, therefore compromises your circulation, so you're not getting good blood flow into the area. Because of that blood flow, you're unable to produce the ATP that you need to actually relax the soft tissue and get the soft tissue back to that normal length-tension relationship that you'd like. So by this prolonged contraction of the muscle as well as the compromise, you just have this never-ending cycle where the muscle is always tight, and then you develop that nodule in there, and now you've got your trigger point. Stemming off of that, there's another one, the motor end plate hypothesis, which is very similar. Instead of it being calcium, they relate it more to acetylcholine. So again, you have that stress, you get some abnormality in your motor end plate or your neuromuscular junction. This results in an increase in acetylcholine being released instead of the calcium. And what that produces is called a spontaneous electrical activity. So if you actually put an EMG in there, you'll notice some actual activity. If you put it in a muscle where you don't have a trigger point, it would be quiet. So you could actually hear the increased activity. From that increase in the acetylcholine, you get this continuous depolarization of the tissue. So again, the tissue stays contracted, you get this taut band, and then you get development of your trigger point. So you get this, again, just like the other theory, you get this never-ending cycle, and you need to do something to break up this cycle. Soft tissue works well, but if you can put a needle into it, you can actually quiet the spontaneous electroactivity, and we'll go over some other things that actually will result when you put the needle in. And then the last one, the radiculopathic model, which is Dr. Gunn again. His is more based on the idea that it's nerve irritation and not so much at the motor end plate. So you get some sort of segmental irritation, compression on the nerve. Because of that compression on the nerve, you get this hypersensitivity in the muscle. This hypersensitivity, which is called Cannon's law, results in a hyperactivity of the muscle. Therefore, you get this taut band again. Because of this taut band, you get that trigger point developing. That taut band causes undue stress onto that segment, continues the irritation of the nerve, and again, now you've got this continuous cycle that you need to do something to break that cycle, or they'll continue to have the pain that they're currently having as well as their dysfunction. So dry needling over time has kind of developed its own terminology dependent upon who you were talking to. So initially, trigger point dry needling was where it started. Oop, knocking stuff over for you, Gary. And then Dr. Gunn came up with his own theory, and he felt like it was more the nerve that was irritated, so he developed the intermuscular stimulation, feeling like he was stimulating more of the nerve than just directly with the muscle. And then the American Physical Therapy Association felt like it was much more of a manual therapy in that you were actually manipulating tissue by integrating the needle in, because you can take and fan the needle around, move the needle around, so you're actually manipulating tissue. So they adapted their own term of intermuscular manual therapy. And as you listen to the video, Kineticorp took that a step further and said, well, instead of just needling somebody and saying, well, do you feel better? Let's see if they actually move better. So you couldn't move, you couldn't touch your toes, you couldn't lean backwards, you had limited shoulder mobility. What does it look like after we actually need it? Does that improve? Is your pain better? Are we going the right direction? Are we making actual changes in your function? So all that's encompassed dry needling. So if you read any articles out there, you could see any of those 5 terms really. All right, so our goal of dry needling is really to elicit that local twitch response. So you actually want to see the muscle actually contract. And what that's going to do is it's going to desensitize that hypersensitive point, that trigger point. And by decreasing that, you're going to reduce your pain and help to restore your range of motion as well as your overall function. So how does dry needling improve and reduce pain? So through 3 processes, it's actually going to help reduce those trigger points and improve your range and your overall function. The first one is going to increase blood flow. So they looked at Doppler studies and showed an increase in upper trap after performing needling. Second, decrease that banding. So with that local twitch response, you're actually going to get that band to break up and get your muscle length tension relationship back again after inserting the needle. And then, like we talked about a little bit before, you get the spontaneous electroactivity by inserting the needle. You've actually, if you go through EMG, you can hear that quiets that actual SAE, so you get a decrease in the depolarization of the actual tissue. Additionally, you're going to get decreases in substance P and CGRP, which I don't remember what that is, but basically they're irritants to the tissue. So if you do a biopsy before and after, you can see that these substances are no longer there. And then you get an increase in what's called the beta endorphin levels, which will help to modulate the pain and make you feel a little bit better by having some endorphins around. Central nervous system, so you're going to have decrease in substance P locally and across the dorsal root ganglia, so it's going to have more of a central nervous effect. And additionally, pressure to that muscle and either where that trigger point is or any place along where that pattern is, it's decreased in its threshold, so it won't be as tender. When you press onto it, you won't get as much irritation in that area. So why do we do dry needling? Basically, we want to improve the patient's range of motion, decrease their pain, and restore their function and get them back to what they were before and allow them to perform at the highest level possible. So increase in range of motion, how do we do that? By increasing our blood flow, reducing that band locally and in segmental muscles, so reducing that taut band that's there, and improve the ability's muscle to move throughout that range. So you decrease that tone in that band, and now you can improve your range of motion because that muscle is no longer tight and taut. Decrease in pain, so you're going to deactivate that trigger point. You're going to decrease the irritation of that trigger point by reducing the hypersensitive, your substance P and other things that will irritate that area. You're going to decrease that SEA, that spontaneous electrical activity, as well as by decreasing the banding, you're going to decrease compression of that tissue locally as well as inside that band. So how about restoring function? You're going to restore the length-tension relationship. So now the muscle will be allowed to go to its full length to return back to where you need it to contract, and then just overall decrease irritation of that area. And if something doesn't hurt, typically you're going to move a lot better. So what can we use in combination with dry needling? So manual therapy works really well. So go in and needle. Now you reduce some of that tone in the muscle. You can go through and do some joint mobs, do some additional soft tissue to really try to free up an area. Then once you've gotten the tissue freed up, you've got those taut bands in there, you want to go in and do some motor re-education. So work on your range of motion, work on specific D1, D2 patterns, whatever you feel like you need to help that athlete get back. And then strengthen the stabilized area. You've got this new range of motion. You've got this new tissue length relationship. You want to make sure you go back and re-educate that. If not, you're going to lose all your benefits of your dry needling. And then go into your functional movements, your squats, your lunges, whatever it is you like to test and make sure that they do well with. and kind of coined the phrase of reset, reinforce, and reload. So once you reset the muscle, reinforce the movements that you want, and then reload the body so that way it can perform the way you want it to. So contraindications, there's a big list of them. Top two are kind of the ones to focus in on too. So consent denied. So if the patient really doesn't want you to do it, it's probably not a good idea. And then inadequate knowledge. If you've never really done any dry needling in the groin area or thoracic cage, it's probably not a good idea to try there and end up with a pneumothorax or something you don't want to be known for. So stay away from there. So complications, potential-wise, so common things, you might have a little bit of pain when you put the needle in. They might be a little sore during or later on. They might feel fatigue later on. It's weird, some people do get fatigued just doing a few needles, and you could get some bruising because you tend to maybe get a little bit of bleeding in there. Very uncommon, you can aggravate their symptoms. They might feel a little dizzy, a little faint because it does affect the central nervous system. You can get a needle that gets stuck or bent. You get that local twitch reaction and you could actually bend the needle. It makes it a little bit harder to get out. I haven't had that happen yet, so I'm happy about that. And then if you're treating the cervical spine, you could give them a little bit of a headache. Rare to very rare, 0.01 to 0.1, an infection of pneumothorax. The amount of bacteria that's on your skin with the insertion of needle, you really don't even come close to the volume you would need to cause an infection, but it could happen. And then things that are less than 0.01, a vasovagal reaction, fainting, you forgot a needle, you know, you left them there for a little bit and decided to go work on somebody else. You come back and be like, oh, you're good, go ahead. Oh, wait a second, hold on. Nausea, vomiting, neurological response or emotional response. I haven't had any of those, but I've heard of some people that kind of have heard a lot more than they wanted to after the session, which I haven't heard that so far. So basically, you're going to palpate around. You're going to try to find this trigger point. Once you find the trigger point, you're going to clean the skin, so try to decrease the chance of an infection. After you've taken and cleaned the area, you want to take and you want to put that trigger point between two fingers so that way you know exactly where you're going to go into. And then they say to introduce it at a 90-degree angle. It all depends on the tissue that's around. So if your thoracic cage is around, you probably don't want to go straight into that way. You want to go away from the bad stuff. So away from your thoracic cage so you don't end up giving somebody a pneumothorax. Arteries, veins, nerves, try to stay away from those. The good thing about it is the nerve is so tough. If you hit the nerve, they're going to get some tingling, some numbness. That'll go away in a few minutes, and the nerve is so strong that it's just going to push the needle away. So causing any type of nerve damage is pretty rare. Artery and vein is just like giving blood. Once you come back out, everything's going to be fine. You might get a little bit of blood, but that'll be fine. Once you get the needle in there, you can piston it, and depending upon how the muscle is, if it's a fan, you can kind of fan out through that muscle. You can go straight up and down. Different areas like the cervical and lumbar spine, I don't piston as much. I'll do more electrical stim. Seems to be more comfortable and have more benefits with electrical stim versus upper body and lower body. Pistoning seems to work better there. And then make sure you remove the needle and apply direct pressure because sometimes you get a little bit of blood. So just kind of stop that from occurring. Post-treatment, reevaluate. So what couldn't they do before? They couldn't touch their toes. They couldn't lean back. They couldn't do whatever it is you wanted them to do. After you've done that, it's okay to stretch. It's okay to do passive range of motion. Instruct the patient in self-mobilization. So stretch out the tissue, your hamstrings, your posterior shoulder, whatever it is that you've just treated, they can stretch it. And the ice seems to help out a lot with decreasing any type of bruising and any type of swelling down the road and any irritation. And then just like a deep tissue massage, if you hydrate, it lessens the soreness afterwards. So how long does it take to work and what should I do afterwards? So typically 1 to 2 treatments, you should really start noticing a little bit of a difference. Over time, you should notice a little bit more. After the first session, you might be a little bit sore. Again, you can use ice, you can use some Bengay or anything to help with the soreness. It's okay to stretch, but I would say like heavy lifting, going in the gym and lifting really heavy, I wouldn't do. You can do some cardio, you can do some biking, you can do some light stuff, but don't go real heavy with your weight training. And then afterwards, your third, your fourth visit of dry needling should be less sore, improvements should occur quicker, and then you can go back to your normal activity a little bit quicker. You could go back to more heavy lifting if you had to. All right, so functional dry needling, we kind of talked about a little bit. And Kineticorp's the one that I did my training through, and they were big on the selective functional movement assessment. So utilization of the selective functional movement assessment is basically, they have 7 movements that they like to see, that they want to see that as you were 6 years old or 8 years old, you could do all these. And you should still be able to do all these, especially with the athletes that you guys, they should be pretty close anyway. So what can they do, or what is kind of normal for them? After you treat them, hopefully what you've looked at, whether it was forward bending, backward bending, their squat, their cervical range of motion, that should improve, as well as hopefully a decrease in pain. You'd love to see both. The pain decreases and the range improves, but at least if you see some sort of range of motion improvement, you know you're kind of going down the right pathway, you're treating the right stuff. So hopefully by integrating specific movements, you can see that you're making a change, you're progressing down the right pathway versus just sticking a needle in and saying, do you feel better? So. All right, so a little bit of evidence to support it. So 2001, leading therapist in management of myofascial pain, they did a systematic review of 23 studies, concluded that dry needling of myofascial trigger points is an effective treatment. 2001, the dry needling technique, intermuscular stimulation of tension-type headaches. So they did dry needling versus a placebo, and they found results in significant improvement in pain and neck range of motion with patients with tension headaches. 2012 is the effects of dry needling in treatment of myofascial pain syndrome, a random double-blind placebo control trial, compared dry needling to a sham dry needling, concluded that dry needling treatment is effective in treatment of myofascial pain syndrome and improving quality of life. So how can we use this inside of actual rehab? So we really want to try to address and manage any acute and chronic injuries, help with soft tissue quality. So we do a lot of soft tissue stuff, but dry needling seems to really reset that motor pattern. So that way we can go in and do a little bit more versus just that soft tissue sometimes just isn't enough. And then neuromuscular balance, kind of getting the body back in balance, making sure that the things that need to be strong are strong and the things that need to be stretched out are stretched out. And how about on the performance end? So improve or facilitate recovery between training sessions. So patients will be less sore, they'll be able to move a little bit better and train a little bit harder. Kind of get rid of that soreness, improve the overall tissue quality, and just utilize this in the enhancement of the whole recovery process. So really allowing them to recover a little bit quicker, get back out on the court or wherever it is. So there you go.